All right, now that we've covered the anatomy of the heart, in this lecture we're going to go into some physical exam signs that you'll see in question stems on either, anatomy exams, physiology exams, board exams, and really, explain to you what these mean so that, when you see these in an exam, they can help you form a diagnosis and understand better what's going on and hopefully help you get the question right. So you have the primary heart sound. So what are these? These are totally normal. This is when you're oscillating on a patient. This is what you'll hear in a normal, healthy person. So you have S1, S2. S1 is caused by closing of the tricuspid and mitral valves, so the AV valves, at the beginning of ventricular contraction during systole. So you have the blood comes in here during diastole, and then the blood fills up, and then they close off. And that's when you begin, isovolumetric contraction. So when these valves close, that's when you get your S1. So you have diastole, like this, you're filling. Valves close, AV valves close. You get S1, then you get systole, which is where you begin, your contraction phase and then your ejection phase, okay? Just to kind of let you know. And this is the lub of the lub-dub. So S1, and then this is S2. So S2 is caused by closing of the aortic and pulmonary valves at the end of ventricular contraction during systole. So you have your S1 where the valves close. You have isovolumetric contraction. Then, the pressure in the ventricles gets greater than the pressure in the great vessels, and you have the ejection phase. This is all systole, by the way. And then you get back here, and then you have the pulmonic, so PV and AV close, and that's what gives you your S2, okay? So it's at the end of ventricular contraction, and it's when the aortic valve and the pulmonic valves close. They have two components, so S2 has the A2 component and the P2 component, and that's corresponding to each valve. And you can actually have splitting of S2 during inspiration in healthy individuals. So if you're oscillating on someone, you tell them to take a deep breath during S2, you can actually hear splitting and actually hear each valve individually. And it's again the dub of the lub-dub. So some extra heart sounds. So if we have S2 here, which is where aortic valve, pulmonic valve close, then you have diastole, so filling. Then you have S1 where the AV valves close, and then you have systole here, okay? So it occurs in the beginning of diastole right after S2. So you're gonna have S3 here, and it's usually normal if heard in children. So if you hear an S3 in a 10-year-old, that's not something to get freaked out about. And it's heard when one or both ventricles are in volume overload. So this would be pathology. Okay, so this would be if you heard an adult. So classically, congestive heart failure, especially on board exams, will often have an S3. And so really when you hear an S3, and as far as the board exam, it gets more complicated in clinical practice and when you get into like a cardiology rotation. But for the board exams, and what you want to think of when you hear that the patient has an S3, you want to think ventricle overload, volume overload, okay? And very often that is congestive heart failure. So that's what you want to be thinking when it's like, especially an adult with S3. Then S4 happens in late diastole. So we're going along, ventricles are filling, and be more down in this later portion of diastole. So both S3 and S4 happen during the filling phase. S3 because the ventricles are already overloaded. So you have blood splashing in here and splashing up against the ventricles. S4 is always pathological. So if you hear it in a child, if you hear it in an adult, doesn't matter, it's always pathological. And it results from blood being forced by atrial contraction into a stiff ventricle. So S4 is very common in aortic stenosis because you've had to, have this ventricle get very stiff and very hypertrophic to pump against this very stenotic valve. Remember the ventricle has to generate more and more pressure. It's just like any other muscle. You're working the muscle even harder to generate the same amount of pressure and flow. Same thing with someone with chronic hypertension. You could hear an S4 as well for the same concept, is you're overcoming a significant amount of systemic resistance. So again, you can hear an S4 that way. So what you're hearing with S4 again is these stiff ventricles receiving blood from the atria, because at the end of diastole you have these atria will contract, and that'll give a kind of an extra kick of blood into the ventricles. Now, this is something you could get asked on an anatomy exam or on a practical, even if they have like a skeletal model in the lab. So, and this is just important to know for as you go into third year and do your rotations. So you want to actually palpate that sternal angle. Now, why in the world would you want to palpate the sternal angle? Because the sternal angle will tell you where rib 2 is. Okay, so this is 2, this is 3. So here you know you're at the second rib, and then you want to know you're at the second intercostal space, and that is where you, on the right side, so here's your right side, this is your left side. On the right side, that's where you're going to auscultate is your aortic valve. Okay, now the reason why you auscultate it, so the aortic valve is like down in here, right? And then the aorta comes up like this. The reason you auscultate downstream is because you're listening for flow. When you have, you know, your aortic valve like this, and it's normal, and you have flow going through like this, normal flow is quiet. You're not going to really hear much. All you'll hear is really just the lub dub, and that's just the opening, or you know, the closing of the 4 valves. That's what you'll hear. Now, if this valve, say, is stenotic, so let's draw a stenotic valve like this. Let's say this is supposed to be when the valve is not opened entirely. So you have stenotic flow through here. This you're going to hear. You're going to hear this stenotic flow. Because, so, you know, the stenosis is occurring here, and then the sound waves are going to go, you know, travel downstream with the flow, and that's what you'll hear. Okay, so that's why you want to listen downstream. And that's the same with all these. Pulmonic valve, you're going to listen downstream. Tricuspid valve, you're going to listen downstream. Mitral, you're going to listen downstream. So let's clean this up, and we'll show you again. So here's right side, left side. Here's your sternal angle, rib number 2, 3, 4. So here on the second intercostal space, you want to do the pulmonic valve. Pulmonic valve is down in here. Again, you're listening downstream, so you're listening for that flow. Then for tricuspid valve, you want to do 5th intercostal space. So second rib, third rib, fourth rib, fifth rib. Remember, the intercostal space is below the rib with the corresponding number. So this is your tricuspid valve. Again, your tricuspid valve's up here, okay? So you're listening downstream. So again, listening for, you know, normal flow is going to be quiet. If it's stenotic or if it's regurgitant, you're going to hear that flow you know, the sound waves radiating down here. Mitral valve, you listen kind of in, you know, near the 5th rib. But the key is actually at the apex, because the mitral valve is going to be here. So here's the mitral valve. You're listening downstream from the mitral valve. Then here's a bonus. If you're doing strictly an anatomy class and you don't want to be bothered with learning about murmurs or physiology, you can just shut the video off right now and go enjoy yourself. If you're curious, or if you're taking physiology at the same time, this would be, you know, probably useful for you. So again, like I was talking about with murmurs. So if you have, you know, heart valve, if you have a normal open valve and you have flow coming through, if you listen with your stethoscope, it's going to be quiet. There's normal flow. Normal flow is quiet. Versus, let's say you have very stenotic valve, so very small opening. Okay, so here you had this larger opening, so very stenotic valve. You're gonna when you listen here, it's gonna be noisy. Okay, same thing here. If you have a valve that's regurgitant, okay, so you have flow going this way and flow going back this way. When you listen, that's going to make noise. So it's all flow getting scrambled. That's what you hear on auscultation. And so what I like to think about with murmurs, especially, is you want to make it very simple. Is you want to think about during diastole, which is synonymous with filling. Okay, what valves should be open? What valves should be closed? Okay, so during diastole, so if we draw the heart like this, so here's our right atrium, here's our left atrium, so we draw the ventricles out like this, here's the left ventricle, right ventricle. Okay, so during filling, our tricuspid valve and our mitral valve should be open. So the AV valves open. Okay, because you want blood coming in from the atria into the ventricles. Then you have your aortic valve and your pulmonic valve. Okay, so aortic valve, pulmonic valve. So So aortic valve and pulmonic valve, or semi-lunar valves, should be closed, okay? They're filling. The pressure is not higher in the ventricle yet than the pressure in the great vessels. So as far as murmurs go, so if you have a diastolic murmur, it's going to be caused by a valve that should be, when it should be open, it's stenotic. So either tricuspid stenosis or mitral valve stenosis. Or it's going to be caused by a valve that should be closed when it's actually open. So it's going to be a regurgitant. So aortic valve regurgitation or pulmonic valve regurgitation. That's what you're going to hear diastole. You're not going to hear, what you need to understand here is you're not going to hear, say for example, you're not going to hear aortic stenosis during diastole, because aortic stenosis is caused by blood being shot out through the aortic valve during ventricular ejection during systole. So that's when you're going to hear aortic stenosis. You're not going to hear it when the ventricle is relaxing and it's filling up with blood. So the things you can hear during diastole are mitral stenosis. You will not hear mitral regurgitation, because mitral regurgitation is when the mitral valve is supposed to be closed. And so it's, during systole, during ejection, you're shooting blood back through the valve into the atria. So you could hear mitral stenosis, you could hear tricuspid stenosis. And then since the aortic valve is supposed to be closed, you can hear that blood coming back through during that diastolic recoil. So you can hear aortic regurgitation. Very rare, but you could also hear theoretically pulmonary regurgitation as well. So these are the three things you can hear that you want to be aware of: is mitral stenosis, tricuspid stenosis, and the aortic regurgitation. Now, as far as systolic murmurs, so systole. So what should be closed during systole? So you don't want blood leaking back into the atria, right? So the mitral valve should be closed, the tricuspid valve should be closed. What needs to be open? Well, during systole, you're ejecting blood out. So what should be open? The aortic valve, pulmonic valve. So if we draw our heart like this, we have our leaflets like this, septum like this, ventricles like this. So here's our aortic valve, nice and open, letting flow come out. Here's our pulmonic valve, same thing. Letting flow come out. So during this, you're generating, the ventricles are contracting like we've been talking about, generating an enormous amount of pressure. Okay, the pressure gets greater than it is in the great vessels. The aortic valve and pulmonic valve open, and then the flow goes out. So if you're going to hear a mitral valve during systole, if it's a systolic mitral valve murmur, it's going to be regurgitation, because the valve's supposed to be closed. So if it's not, it's leaking. You're going to hear it's going to be either mitral regurgitation or mitral prolapse, which essentially leads to mitral regurgitation. So that's what you can hear on mitral. On that, you can hear, so again, the tricuspid valve is supposed to be closed, so you can hear tricuspid valve regurgitation, regurg. Then on systole, so since the aortic valve is supposed to be open, you're going to hear problems with opening of the valve, so stenosis. So you'll hear aortic stenosis. And then with pulmonic valve, it's supposed to be open. So if it's problems with opening, you're going to hear pulmonic stenosis. So I hope this helps. This is, a good summary. You want to think about it's systole versus diastole. It'll always tell you. Okay, it's a good system. What should be closed? What should be open? Same thing. Closed, open. Systole, you're pumping. You want the mitral valve and the tricuspid valve closed. So if it's a problem with closing, it's usually regurgitation. So if you hear a systolic mitral murmur, it's going to be mitral regurg. Now, what you want open? You want your aortic valve open, your pulmonic valve open. So if you hear a systolic aortic valve, it's going to be a problem with opening, so aortic stenosis. Same thing with diastole. What's supposed to be closed? The aortic valve, the pulmonic valve. So during diastole, if you hear an aortic valve murmur, it's going to be a problem with leaking, so regurgitation. The aortic valve is going to be closed, so that's the aortic regurg. Diastole, the mitral valve and the tricuspid valve are supposed to be open. So if you hear a mitral valve murmur during diastole, it's going to be a problem with opening of the valve, so mitral stenosis. All right, so very quickly we've put together this summary so you can help distinguish the different mitral valve murmurs. So first with mitral stenosis. So you hear an opening snap. So diastole begins, the filling, the mitral valve tries to open. It's very stiff and fibrotic, and it tries to open, and that's what you hear. Then you hear the blood trying to get out, and during diastole, and so that's where you hear this mid-diastolic rumble. So again, you hear the valve opening. Remember, the valve does not open because of the papillary muscles. It opens because of the pressure gradient. Valve opens, flow starts, blood starts flowing in. Doesn't get through. You're going to hear this mid-diastolic rumble. Mitral regurg, very opposite. So this is during systole. So the valve is supposed to be closed, but in fact it is leaky. So you have, blood coming out through the aorta, and then you have blood going out back through the mitral valve. So regurgitation, you're going to hear at the apex because it's downstream from the valve. Mitral prolapse, mid-systolic click, followed by a regurgitant murmur. Again, if you remember with prolapse, so we'll come down here. This is where, remember, like that bent, almost bent or bulging. So again, you have pressure built up during ventricular contraction. Blood is going out through the aorta. The pressure pushes up on the prolapsed valve and causes it to bulge into the atrium, and then you have regurgitation. So that mid-systolic click, so systole happens, pressure pushes up, it causes this to bulge, that's your click, and then the regurgitant murmur is the subsequent flow that regurgitates through the leaky valve. All right, so lastly, the summary of the aortic valve murmurs. I know it's been a long haul, but thanks for sticking with it. So aortic stenosis, again, so this is a problem with systole. So you have the aortic valve is supposed to open. So let's draw it like this. It's only opened a little bit, so it's a much narrower lumen. So that's why it's going to be a huge shot. Remember, it's like the ventricle has been building up and contracting, and then it shoots through this very stenotic valve, and it's going to be, it's almost, I've heard it described as it's almost like sticking your thumb on the end of a hose. So you have this streamlined jet of blood. So that's what you're going to hear, this harsh systolic ejection murmur. And then the sounds radiate into the neck because that's what's it's going to radiate up the carotids and into the neck. So then you have aortic regurg. So then, if you remember, you have your aortic valve. Your aortic valve is supposed to be closed when in fact it is actually open. And so if you had these stretch out during systole, then during diastole, the diastolic recoil of the aorta, it's going to shoot blood this way like normal, but then it's also going to shoot blood back through, and this is what you hear. And remember, this recoil is going to happen right away, because once you lose this pressure of systole, there's nothing pushing out on the aorta again. So then the elastic tissue will recoil. Early diastole, that's what you hear, this murmur, left sternal border, and especially with the patient leaning forward. Bicuspid aortic valve, it's the same thing. You have a dysfunctional valve during early diastole. If this is open, it's going to you're going to hear the blood regurgitating back through it. All right, so that closes out our discussion of cardiac physical exam signs. The next lecture is going to be our last lecture about the heart, where we're going to talk about the coronary circulation.